over to Maritza. I'll ask everyone to try to mute themselves so we don't have extraneous noise. And I'll ask Maritza to unmute herself and introduce Ellen Leahy, our speaker.
Okay. Yeah, I'm so thrilled that Ellen could join us today because, I get to work with the health department pretty much every day, and I have been since this pandemic started. And they have so much information that it's hard to pack into our newscasts, and they're such a great source of information. And with this, through social media, there's so much misinformation out there. So I just thought it'd be great to have Ellen. We asked Cindy first because I know Ellen's so busy, but Cindy's on mandatory respite this week, and I'm so grateful that Ellen was able to hop on. So I just thought it'd be great to have her kind of talk about where we're at and open it up for questions, because I know people have a lot of questions about this.
Well, thank you. Thanks for the invite to someone from the health department. And when Cindy found a chance to get that 1 week that we require that you try to get off, as we usually do, I said, sure, I'll cover whatever. And then she said, by the way, I have a presentation Wednesday morning. So I haven't really haven't prepared any sort of a lecture. I've looked at the group. I know you must be a very special group because we aren't giving presentations generally. So, and I certainly recognize some of your membership and very pleased to have been invited. I think what I'll do is present some things that probably many of you have looked at, but if they can provoke discussion or questions, I know this group is more than able to get some discussion going. So we'll start with that. I am just going to dive in, just like we do twice a day at our incident command briefings. And I'm looking for that little share screen button. Come on back. Come on back. Let's move this over here. I think that's what I need to do. Yeah, it's just a little different than ours. Well, I've got lots of screens. Let's see, which one do I want you to see? So you've probably been checking the state website. But I'm going to start with that because things change every single day, and we check it every single day. So I think that's always a good check of where are we right now. And essentially where we are in a metaphor is, this is where we are on a map. It shows us where our journey started. I think my cursor, I'll put it down here to the lower right. And you can see our first, what's called our first wave here in Montana. And right down here, you can see the shutdown, and you can see a pretty clear effect.
Yeah, Ellen, we're not seeing your screen.
Okay. Well, let's try that again. Now are you?
Yes.
Okay. Well, there's two little share buttons you have to hit. Okay. So now I can't see what I'm showing you, but we'll just go right along. If you look at the lower right-hand corner, and you'll see what we call the epi profile or the epi curve, usually with a respiratory disease, you don't see as much of a curve as you see a spike, and that's just the nature of respiratory diseases. And so you can see, can you actually see the whole epi curve? It's blocked on my screen.
Yes, I believe we can see it.
Okay. So you can see we have the first spike that you're well aware of, and that we all expected some profile that was spiky or first wave looking. And then sort of in the middle, you see a little bit of activity, but definitely very diminished. And that is the effect of the shutdown, the 1 month long shutdown that we had. We do have a 14-day incubation period for this disease. The mean of that is 5 to 6 days. So generally, you know, we're seeing cases probably 5 to 6 days after they were infected, but they certainly do appear earlier and they do appear later. So for data reading purposes, you can look at this curve and say, well, you know, they got infected 5 to 6 days, give or take, before you actually saw, and this is their onset of symptoms. So this is not their test date that's plotted, it's onset of symptoms. And early on, as you might recall, it seems so long ago now, and it actually seems so absurd, we weren't able to just test. If you had what was considered an extremely qualified candidate, and by that I mean they had to have been admitted to the emergency room, so their symptoms had to be severe enough, admitted to the hospital, severe enough to have been admitted. They needed to have what were then considered the classic or the sentinel symptoms, I would say at that point, of respiratory pain with respiration, shortness of breath, and fever. So one of those three or some combination. And if the patient did not meet that criteria, you could not get a test. I mean, we actually the hospitals had to ask us, and then we had to ask the state health department, and then the state health department had to then take that patient information to CDC and say, okay, we want this person tested. And then the test actually went to CDC. So it was pretty laborious. And I think that we would have missed cases whenever you've got a new viral caused disease and you don't know what all the symptoms are. But we certainly would have missed cases even, you know, I don't know how many timefold, because we couldn't just test them. And we couldn't see them. And if anybody thought they were sick enough to go to the hospital, one person sick enough to go to the hospital is another person not sick enough to go to the hospital. So all those things were going on. And so we know that there's a whole shadow or perhaps an enhanced spike here that was completely missed. I can't apply any metric to it. There's a lot of epidemiological look back work that's being done to try to say, well, for every case that we caught in the US, you know, we missed 9, but you know, a pandemic, you don't know what it's going to do until basically it's done it. So we capture the data we can. And so you can see this, if you've, you know, read anything about pandemics, you know, you're going to have what's called that first wave. Nope. So that's what we had. And then we had the shutdown, and then we expected to see cases. And now you can start to see that second level of activity occurring in the state. So the state, if we look at the whole map, I think it's wonderful that they oriented us to the United States here. I just want to get us into Montana. Not sure why we had to see the whole US. There, let's get us into Montana. Okay. From the beginning, here we have Gallatin County. And as I realize I'm repeating some things, but I, again, want to get us into the now. So I'll do a little bit of storytelling. Here we have Gallatin County. And from day one, they've had the most cases. They were the first county to go to identifying what we call community-wide spread. So if we can identify that a case was had just returned from travel, and travel was a very important case definition early on. You actually had to have been to China in the early stages or been with someone that had been to China to even get a test, as well as have symptoms. And then you had to have been to China or Europe to kind of make it through that absurd testing gauntlet that everyone had to go through. And then as it started spreading in the country, we started looking towards Seattle, because Seattle and the Providence Hospital there was really the first one in the western part of the country to get hit. So many of our lessons learned are actually from that system, which was really helpful here in Missoula, having Providence System Hospital at St. Pat's. So Gallatin, I don't remember what they got in the first spike, but they very quickly put them down, and put them down means you find the case. You've heard of contact tracing. Contact tracing is, it is like just the ancient mainstay of communicable disease control when you have no other way to render somebody immune so that they aren't contagious. So you find a case, you identify everyone that meets a certain level of contact. And for this disease currently, that means you've been within 6 feet of that person for at least 10 minutes. So yes, you could get infected by passing someone in the hallway who coughs on you. Yes, you can get infected by touching a surface, touching your face. But it's just not feasible or necessary to identify everyone who may have passed it in that way. So we go using the current contact tracing definition of within 6 feet, not masked or any sort of personal protective equipment, and at least 10 minutes duration. So this disease is primarily respiratory spread, as you know. So that's why we have that definition for who is a contact. And then a contact is quarantined for 14 days. And even if they are tested, and now we have enough testing available to test that person, which is now the new recommendation, is test the contact. Don't wait for symptoms. Even if their test shows up negative, because the incubation period is 14 days, they are quarantined for 14 days. So, I'm rambling around here, but it's kind of more of a storytelling. So anyhow, Gallatin County, in my estimation, I think they had 70 some cases, quickly, as soon as testing became more available, they found cases. They were just there and spreading, waiting to be tested. And they believed it first that it was related to travel, and it may have been, but they actually divided into 2 major clusters in Gallatin County. Once they broke out of those clusters, and they couldn't say, well, this case just traveled, or this case, was a contact of another case, then you have what's called community spread. So generally, when you start seeing cases that you can't connect to other known cases in that proximity of time of spread, that 14-day period, that generally will be judged community spread. So they went into community spread real quickly. And why do we worry about community spread? There's so much of an outbreak, epidemic, pandemic that is invisible. It's not like a fire where at least you see smoke, if not flame. You have to find the cases. You have to find the cases. And when you find the cases is the way you find the next cases and the next cases. And so with community spread, if you've got case A, and they don't seem to be related to case B, and neither of them traveled to China, and you've got case C or D, and they don't seem to be related, you just know you've got more cases, and you haven't seen that whole web or that sort of hierarchy or pyramid of other cases. So they got into that really quickly and put them down. And then with the closure, they were able to keep them down. Now, in contrast, Missoula, we have the same number of cases that we had in the first wave. So we counted as 42 cases. The state does not count cases that we call epi-linked. An epi-linked case is someone who was definitely in contact in a way that could spread the disease. So a true contact with someone who has a laboratory confirmed case. But for whatever reason, you couldn't or didn't get the test while the test would have still shown positive. And that's called epi-linked. And the state has not yet determined their system for defining epi-linked cases. It's something that with diseases that are known, there's already a definition and you don't have to create one. And they haven't yet determined then how to show or count them. So when you look at Missoula County, you'll see the state has 40 cases and we actually had 42. And I want to amend that quickly. And Maritza played quite an important role yesterday or the day before. The days fly by. So we had the shutdown in Missoula County, just stayed at 39 or what we called 41 cases because of the epi-links. And we had 2 full incubation periods before we got another case. And I'll go over that a little bit more when I show you our epi curve. But that case turned out to be a false positive. This particular test, it's a very good test. It's a PCR. It's looking for the DNA associated with infection. If the DNA is present in enough level, which doesn't take a lot, and if you get that swab up the nose far enough, you will find it. It will find it. I mean, it replicates it, it multiplies it, so it can find it. However, if you go too early in a case and the body hasn't produced, the infection hasn't produced that, you get a negative. And you don't really know unless you test again if that was a true negative or if that person was just tested too early. We had, and so once we opened up again, we started seeing our hospitals do elective surgeries. And so they were doing, appropriately so, they were doing screen testing before going into a procedure. And we had gone 2 incubation periods here in Missoula with no new cases, and our testing has well expanded. The health department started its own same day or next day testing on a drive-through basis, and we have takers every day on that. We haven't had to turn people away like we did early on for testing. And so we got just popped up after 2 incubation periods, this one lone test. And so we thought, okay, we're starting to spike up like we saw down here in the right-hand corner as they are in other counties. But then no other cases popped up and we couldn't figure out where this person got it. So we figured it's community spread. There's definitely more cases. We just need to find them. And that never happened. And so the infectious disease doctor, he started thinking, this is a false positive, which you don't see a lot of. You see more false negatives. And so the person was tested again, and we used a different lab, and it was negative. And just to give it one more good go, was tested again and interviewed again to really look at, what connections might you have had. And so yesterday it was judged a false positive, and so our case was removed. Well, while we were having that little drama, very small drama, what we have going on in the rest of the state, which can happen here. Oh, now they're trying to get me on another meeting. I hope it doesn't make its way through. Okay. It can happen here at any time. I mean, we're like, where are the cases? So what we've seen since in all this activity over to the right down here on this epi profile is occurring in Gallatin, Bighorn, and Billings. So Bighorn has had a huge and continually growing outbreak. It includes A lot of contacts that originally were on the Crow Reservation, so large community, large family, a lot of gathering. Um, looking at the Crow Reservation as one large and in many cases familial community. And they've gone beyond that cluster into community spread and elsewhere in the county. So this is a lot of cases for that particular county. Billings being Billings, with kind of in and out traffic in Billings in our largest city, and being adjacent to this activity, has garnered a lot more cases in the second spike than in the first spike. They held really low. I don't remember their numbers, but it was less than half of this. And then Gallatin started picking up again, and they're picking up with a lot of activity this week. And as you might guess, as being a gateway to the park, and the park having been open since, or at least the Montana entrances to the park have been open since June 1st, but the Wyoming entrances to the park were open before. So they're definitely seeing activity across the county, but some hot spots in West Yellowstone. So when we kept things closed, this virus travels by people. And so if you don't let people in or out and you keep them 6 feet away and they don't interact, it's not rocket science that it's not going to spread. But then it gets real complex in terms of how it's going to spread as you gradually reopen. So that's really where all the activity is at the moment. However, with a 14-day incubation period, we could have a number of cases here that we just haven't found yet. And they could have spread it to a number of people that we also haven't found yet. So that brings us to the contact tracing. In a couple of ways, Montana is very fortunate. We're not a coastal, we're not Seattle, we're not California, we're not New York City or Boston. And so when the disease traveled from China and Europe, and the genetics are showing that we originally had more travel seeding of the disease from China, obviously on the West Coast, and more seeding of the disease from Europe on the East Coast, which makes geographic sense. That's being mixed up with the type of spread we've seen since. And we were neither of those. So we just kind of had to wait till somebody brought it to the state somehow. And that we didn't have to wait very long, but we are not a gateway city. We have another gateway city to national park, city and county up here in the Flathead. And you can see their numbers are still low at 37, but we have Glacier opening up. I think it was this week they began to open up, and the Canadian border is still closed. So they still have a certain amount of protection. I'm not speculating here, I'm just kind of pointing out that also geographically, we look at things as a state, we count our numbers by a state. What our governor does and his directives are statewide, but geographically, we're much closer to Idaho than we are to this type of activity over here. And Idaho actually had more quick, more lengthy, and more stringent closures and reopening guidelines than Montana did. So you do have to wonder if we did get some level of protection from that or not. So that's where we are in the state right now. Testing is widely available. The message we've been trying to get out with testing, though, is that even when we could test for symptoms, and we were messaging that, we were still going with the 3 cardinal symptoms of shortness of breath, pain with respiration, and fever. However, it's been well over a month now that the Centers for Disease Control, based on case evidence, have added 6 more symptoms. And you, I know many of you and many of your names and some of your histories, I'm sure, are very well studied on this. If you have any interest in, why wouldn't we have interest in it? But even I have trouble remembering all the 9 symptoms. It's like, what flavors of pie do you have today? I could give you 8, you know. But some of them you're not going to think respiratory. You're just not going to think respiratory. So we're trying to get that message out, because the symptoms can be chills and shakes, which, you know, sometimes you get that when you get sick. Muscle aches, actually diarrhea. They've actually found the virus in stool. So diarrhea, you know, you might think you're sick, but you're not thinking a respiratory virus. Let's see, one of the odd ones that has now been shown to be evidence-based, we started seeing in just our small number of cases in Missoula, and it's a new loss of taste or smell. Many of us have had some diminished taste or smell, or may have allergies, may have been getting over a cold or something back in the winter when this hit. But this is a new loss of taste or smell, and it can be the only symptom. So we started seeing that in our interviews, and our infectious disease advisors were looking at that well in advance and unsolicited. We don't say, did you have a taste of loss or smell? We ask people, what are your symptoms? What symptoms do you think were associated? So now that has an evidence base to it, and so we look for those. Fever may not always be present, and simple things like you just feel like you're getting a scratchy throat. You hope it goes away. Well, it might go away, but those are signs to be tested. All of those are signs to be tested. You can get tested at your provider will probably, your healthcare provider, show you to or guide you to the 2 main testing areas. Community Medical Center has set up one, and Providence has set up one. And they directed their flow to those areas so that they could keep well or other affected patients away from potentially COVID infected patients. And they continue to maintain that kind of separation. And then when the health department was able to get testing materials, which took, it took a lot of pounding on the table. It took our mayor, it took our commissioners, it took our health board, it took the hospitals, it took Rocky Mountain Lab. I know I'm opining here, but it was absurd what it took to get some testing materials in order to test more people, to do it on a no cost basis, you know, just basic public health available testing. And so we've been running that clinic since I don't know how long, but we had it staffed and set up, and it was just waiting for test swabs, literally waiting for a certain type of Q-tip for almost a month.
And now it's muted. Yeah, it's on mute now. I wonder if it's.
Oh, so I will shut up long enough before I go to another slide and see what questions you have on my yakety yak so far.
Ellen, this is Maritza. First of all, I'm sorry. I didn't mean to cause any drama in your office this week with the state and the false positive. But I'm wondering, how do they know that yours was false positive and theirs weren't false negative? Because we've heard of that way more than we've heard false
right.
positive.
So that gets it's, you know, again, it's not something none of us could understand. It's a little harder to explain, but and I don't want to get too far into the person's personal health situation, even though the person's not named. But I will tell you that you also look at the context. And the person in preparing for a surgical procedure had self-isolated for weeks. There was no contact, you know, beyond a quarantine period. Those were the instructions. Person carried it out. Also, a different lab than usual was being used. Could have been contamination in the lab. Without blaming the lab, let me just put that aside. When you are in a situation, and this is just going to seem really counterintuitive. So I've explained how you get a false negative. And it's really, I'm not sure it should be called a false negative because the DNA isn't there yet. And if you test 5 days later and you're infected, you're going to get a positive. So I would say it's an early negative. If the person has symptoms, you know, give them a few days and test them again. And then you're going to get your true reading. But again, and it's very counterintuitive, but all types of tests have what's called a predictive probability. And that's a metric that is based on the performance of that particular type of test. It requires that the testing, the sampling and the running of the test was all done correctly. It requires, of course, no possibility of contamination in the lab with the reagent or anything. But when you test in a population, which Missoula appeared, at the moment still appears to be, but I don't trust that has very low prevalence. So you can say Montana compared to the country that's a relative term, has low prevalence or prevalence. You can say these counties compared to other Montana counties have a higher incidence or prevalence. Incidence when it appears, prevalence as you're getting through it. But when you run certain tests in a low prevalence population, the statistics alone, because your denominator of how many positives, how many infected people are really out there goes into an equation, you actually will see more false positives. So we see this when we're running, or our healthcare providers are running flu tests a little too early in the season, but sometimes the flu travels from, someone traveled, or you get a cruise ship group that got the flu, somewhere else where it is prevalent. But sometimes they'll just run them because they can't figure out what else is going on. It's appropriate to test for flu based on the, should we give antiviral question. And you'll get a positive, but you have to look at your overall prevalence of flu. It's not flu season. And you really can't be sure that that's a true positive because of that counterintuitive predictive probability that's related to how high or how low the actual disease prevalence is. So that's where we're at.